I'll explain that one in a minute.
Okay.
Hello, everybody. This is Monday, September 15th, 2025, an unusual day for a podcast from the HCMA. But yours truly has been traveling way too much lately, and nobody's been available on Fridays because we've all been at different conferences. So, sorry for the delay or the lack of content over the past couple of weeks, but we are back. Marty Maron is with us today. Good morning, Marty.
Good morning, Lisa, and everybody tuning in. Good to be here, as always.
Always great to have you. And we had some exciting news out of Madrid, Spain, at the ESC conference, so European Society of Cardiology. And it ties in very nicely with our theme of the month for September, and that is septal reduction options and emerging therapies to manage obstruction. So, Marty, can you tell us a little bit about the MAPLE trial? And we'll talk a little bit about Odyssey as well, but let's talk about the MAPLE trial. What was it? What did they look for? And what did we learn?
Sure. So, I think that the MAPLE trial was addressing, it was a clinical trial that was addressing, one of what, has to be considered one of the fundamental practice patterns that we've had for HCM for almost now 60 years, which is that we have been using and recommending as well in the guidelines beta blockers as a first line treatment for symptoms related to obstructive HCM. So patients with obstructive HCM who have symptoms attributed to the gradient have been started usually initially as monotherapy, single therapy with beta blocker as that first line therapy, as I said, for more than half a century now. Okay. And that's been, by the way, that practice has been done and recommended based on kind of really very little scientific evidence. I mean, we've had some, of course, that have shown that beta blockers can lower to some degree that pressure gradient, particularly with exertion, not so much at rest, but with exertion, and that may be one of the mechanisms that would be beneficial to improve patients' symptoms. And so that's, again, very little, but some data related to that. And that's sort of really it. So we've been doing that, as you know, for a long time, right?
Taking a few beta blockers in my life.
That's right, as I'm sure many people listening, have, including being subjected to some of the side effects of those drugs, et cetera. And so with that as kind of the background, MAPLE HCM trial said or asked the question, well, we have now kind of more potent drugs that have shown really good efficacy in obstructive HCM, making patients feel better, function better, and are generally very safe with little side effects. These are the myosin inhibitor drugs. And they specifically asked the question, this second-in-class myosin inhibitor, aficamten, how does that look if we start that drug as first-line monotherapy, and we compared the efficacy there to a beta blocker? So it was a head-to-head trial comparing aficamten to beta blocker, metoprolol, to try to understand how it did for patients in terms of making them feel better, function better, side effects, safety, etc., over a 24-week period of time. Okay? That was the question that MAPLE was asking. What MAPLE found in that study was that aficamten, the myosin inhibitor, was superior to a beta blocker in terms of almost all of the endpoints that we evaluate patients with in these clinical trials, including how patients felt. So they've improved significantly greater with the aficamten versus metoprolol. They also function better. Their exercise performance was much more enhanced with aficamten than a beta blocker. And in fact, on that point, beta blockers actually worsened patients' exercise capacity, not just not better, but worsened.
Okay, let's stop there for a second.
Okay, before you do that, let me just summarize it by saying, in addition, fairly safe and well tolerated versus beta blocker as well. So overall, the message there was that aficamten, by all the indicators that we look at for these studies, was superior to a beta blocker in a head-to-head comparison.
Do you feel that there were people surprised at the decrease in exercise capacity of an individual on a beta blocker for obstruction? I thought people were a little, from the audience reaction, I think they were a little surprised. Do you think that was an appropriate response? Like, what did you think?
Yeah, I think it was a little surprising maybe in some ways, because it was sort of the first time we've actually sort of seen it so obvious and objectively laid out like that for a beta blocker, I mean. But mechanistically, it's not that surprising, actually, because based on how beta blockers work, they work as part of how they do it is they will be blunt, or they mitigate the heart rate response during exercise. It's not, for those who've taken this may know, but your heart rate doesn't increase a lot of times appropriately to the amount of exercise that you're doing. It's called chronotropic incompetence. It's a fancy word, but it just means your heart rate doesn't go up, right? Because the beta blocker is blunting that. And if your heart rate then doesn't go up enough with exercise, you're not going to perform as well as you would otherwise. And so that can impact the exercise performance on a beta blocker, which is what we call the peak VO2. And so by that mechanism, it wasn't all that surprising, because we've known that beta blockers can do that, actually. So in that sense, not to me, at least, and many others, not that surprising. But I think for many others, it was, who are, there you go, who are not as initiated to the mechanism of beta blockers, it could have been kind of shocking. And here you're showing the figure from Maple demonstrating what we just spoke about. Aficamten is in green there, and you can just see very easily the change in exercise capacity from BL is just the baseline before the trial starts, and 24 is the end of the trial, week 24. You can see it goes up with aficamten. So exercise performance in patients that got the drug increased, while beta blocker here, you can see very clearly, decreases over time for the reasons that we just spoke about.
Okay, so I'm going to pull this down. I wanted to get that slide up, but excuse the format that it pulled up in, but it was the one that was on the big screen in Europe. So we know that in this particular trial, beta blocker versus a myosin inhibitor, in this case, aficamten, the second in class myosin inhibitor, which is not available on the market yet and has a hopeful label date of end of December of this year. So it'll be available early next year if it gets to label, which we believe that it will.
Right.
But you never know. Right. So we have this information, and I'm going to ask you a loaded question that I know the answers to the negative. Does this mean beta blockers don't work in any way in HCM?
Well, I think what it means, so you're asking, how do we translate these results? Into
practical application.
Yeah, for patients, right? That's the big question. And I think here's what I would say is that these results are, overwhelmingly compelling in many ways for supporting a change in practice where it would be very reasonable to offer a symptomatic obstructive patient aficamten, if it's approved eventually, as a treatment at that earlier stage than we are now. And by the way, the cardiac myosin inhibitor drugs are currently kind of as add-on after beta blocker. Okay, so I think what these data being so compelling,
Paradigm shift.
right? They shift things where it would be reasonable then for any individual patient to be considered for aficamten as first-line monotherapy. I think these data support that. Now, likewise, that doesn't mean that every single patient has to be started on a myosin inhibitor initially either. I think that what I would say is that there may be other reasons selectively that a patient could still be considered, for a beta blocker. There are probably patients, by the way, even though, this trial didn't clearly show this, but there are probably still patients, who could get a response to gradient lowering with a beta blocker selectively. I don't think it's, nearly as comprehensive, of course, as what you would get with aficamten, but there may be some patients whose gradients can be lowered sufficiently enough that they could feel better with a beta blocker. Okay. The only way to know that is to try them on it. So I think that means that, so essentially and obviously beta blockers are cheap, they're relatively safe, they're easy to administer. So what I think that this means is that it has to be individualized. It doesn't mean that it's wrong or unsafe or incorrect or bad to offer or consider beta blockers initially. I think it puts much more weight, though, on providing patients the opportunity for aficamten as initial therapy, for sure. That was a little bit of a long-winded answer, but I hope that that's clear, at least kind of on how I would interpret the data.
I would look at it much the same. Sitting in the room, listening to people just give their feedback in real time. Number one, I want everybody to know that it was in the late breaking and it was well populated. It was main stage type work. And then there was a secondary meeting of Ask the Trialists, which Marty was on the panel for. That was standing room only as well. And there were probably 300-400 people in attendance for that.
Right.
I only say this to illustrate that HCM has moved from the last day of the conference in the last room with the least amount of attendance to the main stage and then some.
Right.
So how does that feel, Marty? Let's just talk about that for a minute.
Yeah, talk about a paradigm shift. I mean, that is a paradigm shift. I mean, I mean, how many times have you and I, been in the room at the end of a conference with really just a few people?
And we knew them all.
Right, exactly. And wondered, felt like we were just sort of being, added on there. But so I think obviously it's an incredible change and really reflects obviously a lot of the progress that's gone on recently with this disease in terms of new therapy. And obviously is such an important ability or opportunity really to highlight the visibility of HCM this way. And you can see it really does create a lot of engagement. People were very interested in the data, as you just said, many standing room only. And so I think it's all good.
I was very excited about that part. I truly was. I did give some live updates to the community, as well as I videotaped the entire presentations in the main room, which you can find on our YouTube channel. My apology for not having the best seating for that, but when I got to the room 20 minutes early, all the good seats were taken already, so I had to be over on the side. So you do hear the data, you are seeing the slides, so if you want to see it in live time, we can do that. You can go to the YouTube channel and Ross can drop some links on that in the comments. So hello, and to the person who commented, I love beta blockers and insinuated that there was sarcasm involved. We all kind of feel that way. But there's still a role for beta blockers in HCM, whether it be for atrial fibrillation or rate control. There's still a purpose to beta blockers in HCM. Marty, could you just address that quickly?
Yeah, no, it's super important point, and thanks for bringing that up. I probably should have mentioned that. So what we've been talking about and what Maple was addressing, the trial, was beta blockers as a treatment for symptoms related to obstructive HCM. Okay, that's different than other indications that beta blockers may have benefit for that still are important, like, as you just said, controlling heart rate if you have atrial fibrillation with HCM, or blood pressure, or other indications that are different than symptom improvement. So really important to understand that this is not a trial that is meaning that beta blockers across the board in every reason should be done. That is not what this was about. This was about symptom management.
Exactly. Thank you for that. A second session at ESC was about the importance of maintaining strong myectomy programs. So we go from one extreme, treating obstruction with a novel therapeutic versus the old school treatment beta blocker. But another segment spoke specifically about how important it is to maintain access to good surgery. You were on that session, you were on that panel. Can you tell us a little bit about where surgery stands today?
Well, I think that that you could say that that there's a little bit of a crisis. I mean, I think for surgery in the treatment of obstructive HCM. I would go as far as to say that may be the case, or if not, we're pretty close to it being in a kind of a crisis situation. And so what do I mean? So what I mean is that, first, we need surgery to continue in this disease at a high level, right? Right. We need that. We need great surgeons. We need access to great surgeons who can perform myectomy at the level that many of the great ones that are still going right now can do it for patients. Why? Well, I mean, it has nothing to do with any kind of negative issue related to the new drugs. The new drugs are great, and they serve an incredible impact right now. There's no question about that. It has nothing to, that is not the debate, or that's not the issue. The issue is that not everybody, not every single patient can be served in a way by the drugs to relieve their symptom burden sufficiently in this situation. Okay. There are going to need patients who are going to still require surgical intervention to restore them back to a normal or near normal quality of life with obstructive HCM. As good as the drugs are, and they're very good, nothing's 100%. And so for those patients, surgery needs to continue and exist and thrive. By the way, as well, there are also patients who prefer, as a preference, to have a kind of one and done intervention for their symptoms. They prefer that because of a number of reasons. Maybe they don't want to be on a drug for the rest of their life. Maybe they want to get fixed and kind of go on and not have to think or feel that they're being held back in any other way by their disease, et cetera. There are a number of different reasons why a patient may still want to have surgical intervention over drug therapy. And we have to be able to provide those kind of patients that opportunity if they want it. And the crisis then is that the expertise that we need to continue for surgery is being, perhaps some way impacted, not to anybody's fault, but by the fact that there are just less patients overall going to surgery. And it's created a situation where we have to start to be concerned about whether or not we're going to be able to translate the expertise of the operation onto the next generation of surgeons to perform it the way it needs to be performed. Okay.
Mm-hmm.
And so that is the crisis situation. Do you agree with that?
I do agree with that. And as I travel the country and we start to develop new programs or go back and look at some of our existing programs, this thing happens, and it's called people age and people end careers. And some people are taking skills out of the market because of retirement. And we need to make sure younger surgeons are trained. And this is not, no surgery is easy to me because I'm not a surgeon. However, when you talk to surgeons, and experienced good surgeons, they will tell you myectomy is one of the most challenging cardiac surgeries in existence. And it is because of the mechanisms that are used to section out the thickness of the heart in the appropriate way. It is mostly a blind surgery, so it's really hard to teach.
Right.
So we need to teach more. We need to make sure the younger generation of surgeon has the opportunity to learn from the older generation of surgeon. And we need to make sure that people have access to know where these higher volume surgeons are located and that their insurance provider allow them that. I heard a case last week where somebody was not permitted to travel out of state to go to a surgeon because there was a cardiac surgeon available. That person's probably not going to have optimal outcomes. I hope they're safe, but we need to make sure that there's surgeons available for everybody when they need the surgery.
That's right. That's right. And I think we're going to have to continue to focus on this issue, maybe even try to create unique strategies that can kind of help address it as we move forward, because I think it's going to continue to be a challenge.
I would agree. And we have a comment from one of our ambassadors, actually, who had a myectomy, but it wasn't done optimally. He didn't have enough resectioning done, and he ended up on a myosin inhibitor as well. I will bring up one other point. I know Marty's time is limited today, which is why we're jumping on a Friday or on a Monday instead of a Friday. I'm going to get back to that in just a second in terms of the potential of using a myosin inhibitor after surgery, either for non-resolved gradient or for symptom improvement. But I want to talk about Odyssey for 5 minutes first.
Sure.
So Odyssey was the trial looking at mavacamten, so Camzyos, in the non-obstructed population. Marty, can you give me your reflections on this study?
Yeah, I mean, obviously there was a lot of interest, as well in this study for the following reasons, of course, which is that, I think we've got a lot of good options to make patients with obstructive HCM feel better. We've got very fewer options, I should say, for non-obstructive HCM. It's probably the biggest unmet treatment need that we have in HCM, or the symptomatic non-obstructive HCM. If you're listening and you've got non-obstructive HCM, you probably understand completely what I'm talking about. Of course, it's very frustrating to be limited in that situation because the beta blocker and verapamil, which are the drugs that we have, often fall very short in providing benefit. And so the hope here was that we were going to see, like we saw with mavacamten and obstructive HCM, a similar kind of treatment effect at making patients feel better and function better with non-obstructive HCM. And unfortunately, Odyssey was what we call a negative trial, meaning that there was not a benefit in making patients feel better or function better if they were taking mavacamten compared to if they were on placebo. And I think that obviously was very disappointing to see for all the reasons we just spoke about. And so essentially what that then means is that there is no clear role for mavacamten in the treatment of non-obstructive HCM. It's not statistically better than placebo right now.
So editorial comment from Lisa. And
Sure.
I put a big asterisk as editorial comment from Lisa.
Sure.
I'm very concerned about the study design here because what I saw from being part of the early myocardia studies in non-obstructeds, the Maverick trial.
Right.
There were 60 patients in the Maverick trial. 33 remained on drug until May of this year, which means they were on the drug for between 6 and 8 years.
Right.
Most of them in the 7-year range. And many of them were asymptomatic, cardiac function improved. There's something for the non-obstructeds here. This trial failed. It doesn't mean that the drug does not necessarily work. Trials failing have a lot of different reasons, and it could be who was in the trial, what the endpoints were that somebody chose. There's something here that I think we still need to dig into because I think there's a role. Obviously, we need to prove it. We need to do the science. We need to have good data. But for those of you who are non-obstructed and we're holding out hope here, hang in there a little bit longer. Something might be coming around the corner. and maybe these other options.
Yeah, I mean, that's something coming around the corner. You're right. I mean, that all those points you made are correct. And what may then, be the answer to those points is maybe coming around the corner, which is another trial called Acacia HCM, which is looking at aficamten. We just spoke about aficamten in terms of maple HCM, the drug used in maple HCM. Here, it's being investigated in the same way that mavacamten was just looked at in Odyssey. But again, aficamten's it's the same class of drugs, but it's also different in its pharmacology, how it works a little bit. The trial design, as you just said, is different. And there are a number of other distinctions here that may translate into a different outcome with Acacia than with Odyssey. So that trial will probably have some information about, meaning results, sometime mid next year, probably.
Fantastic. Okay, Marty, I want to be respectful of your time because I know you're on a short schedule today. Yeah. Any other comments or thoughts for our listeners today on these trials that we have addressed? Some optimistic news, it's some pessimistic news. Can you round it up for us?
Well, I mean, I think, it was sort of an up. I think in the last half hour, we've been sort of up and down a little bit. Obviously, a lot of up with Maple and the opportunity to maybe advance the treatment of obstructive HCM by considering aficamten as a myosin inhibitor earlier than what we are now based on the results of the Maple. That's really positive. I think that's going to benefit an enormous number of patients. I think those patients are going to get in benefit earlier than they would otherwise, and more complete relief as well with that. And so I think that is a paradigm changer in that sense. And I think we've sort of reversed with that almost 60 years of practice pattern. And that's huge. I mean, that hardly ever happens, almost ever in cardiology. So that's a really big step. And I think the story that you just said about, about non-obstructives and Odyssey is disappointing, of course, but I think that story is not over yet. So I think we need to just try to hang in a little bit longer. And not only, by the way, let me just mention one other thing. Not only is there going to be the results of aficamten and non-obstructive HCM, but there are also other drugs being investigated for non-obstructive HCM, including different number of trials. Metabolic modulator, SGLT1 and 2 inhibitors, those kind of drugs that are being looked at also in the non-obstructive population, and also other MOS and modulators to see if there's benefit. So there is lots going on. So that's the other optimism on that end. Okay.
I would agree with you on that. And I would tell people to stay in touch. If you're interested in the SGLT1/2 clinical trial, sponsored by Lexicon, you can contact the HCMA office and we can help coordinate you with a site coordinator so that you can talk about that trial a little bit more. We've done a previous podcast on that and webinar. We're going to do an update in a couple of weeks. Ross, if you could drop the link. I know you got to go digging for that one. It's a little bit back there. But there's a whole presentation on our YouTube channel. And I just wanted Fortitude. Thank you. There's too many names of too many trials right now. I need to put them in Post-it notes in front of me. So we have Fortitude coming up, and we have another trial coming up this fall in the non-obstructives for people who were involved a couple of years ago. We did a phase 2 with a company called Imbria, and Marty, you were a PI on that project. Do you want to give a 2-minute shout out to what we're going to be looking for come the fall?
Yeah, I mean, this is a drug called niraparib. It changes the energy utilization of the heart to make it more efficient. So you're saying sort of shifting that chemistry in the heart to make what the heart uses to relax and pump more energy available for that, making it sort of hopefully more efficient. Hopefully, therefore, translating into an improvement or optimization in filling of blood and therefore cardiac output with exercise, the kind of things that we want to see change to make patients feel and function better with non-obstructive HCM. And so it's a very, interesting mechanism. It showed benefit and a signal for benefit in the phase 2A study, giving a lot of enthusiasm to this study. So if you're interested, contact Lisa.
Soon. You'll get the notice soon. Lastly, I will just say that in October of 23, we all met together to talk about clinical trial endpoints. And one of the things that we determined was that in HCM, the Kansas City Cardiomyopathy Questionnaire, KCCQ, was not specific enough for us. So we have been working with the team there to develop HCM related KCCQ, so KCCQ-HCM. Ross, if you could drop a link to KCCQ-HCM, that would be really beneficial because we need a few more people to give us their input. We've got somewhere in the 250. Thanks a lot, Marty.
Thanks,
Checking
guys.
out.
Okay,
Take
thanks,
care.
Lisa. Talk to you soon. Thank you.
Thanks. Take care. I knew Marty had a short window with us today, but I was trying to get that last one in. So we were all working together to improve KCCQ so we have better clinical trial endpoints. So if you can drop that link, Ross, for KCCQ HCM that's in Charles's email, we can drop that in here and people can take that as well. And we need to get as many people as possible to answer that to make it the most realistic and accurate tool we can make it. So we'll get that one up there in just a second. Lastly, I'm gonna take a few minutes to give you an update of where the hell I've been in the past couple of weeks. I'm in a lot of places. So starting back about 4 weeks ago, I was in Madrid, Spain, for the Global Heart Hub Conference, meeting all of our advocacy partners from around the world to combine our efforts to put a message out that's a little bit more broad about understanding cardiomyopathies in general and how to get to diagnosis. So we all met. We talked about all the things we're doing. We have some of our HCMA international affiliates there as well. I think 4 of the countries were our affiliates. So it was really great to see all of them and start to get organized for 26. We kind of start our next year way ahead. So that was awesome. And then, as I mentioned, I went to the European Society of Cardiology meeting. And we met some amazing people in person there. This podcast is reaching more people than I ever dreamed that it would. I have to give a shout out. I don't know if he's going to watch this one or not, but my new friend Lucky from the Philippines, who was really excited to meet us. And I'll put some pictures of his engagement at our booth later. Big shout out to Juliana Krem, our contractor from Brazil, who did an extraordinary job at the booth. We got some really great contacts, and there's a lot going on in this space. So I was in meetings, getting the science, getting the relationships built. We spoke to the Chinese Cardiology Association to see what we can be doing with them. We spoke to, of course, our friends at AHA and ACC. So, like, we're really trying to make sure HCM is front of mind for all of our cardiology friends. So I left there and I got home for a whole day, and then we pivoted to Nashville to the ASC conference. So it gets a little confusing: ESC and ASE. So that's the American Echocardiography Society, and that is run currently. The outgoing president was Ted Abraham. So big shout out to Ted. Dermot Phelan, who some of you may know, was the curriculum lead this year. He did a great job. And thank you to our 5 volunteers and your big hearts for being live models for echo screenings. That was a great project, and we taught a lot of sonographers on how to find different anatomies in HCM. So thanks to the people who showed up with their various cardiac anatomy, including apical HCM, apical aneurysms, mid-cavity obstruction, traditional outflow tract obstruction, and a non-obstructed. So we had a whole bunch of different anatomies that we were able to teach sonographers with. And there's nothing that compares to doing it on an actual person with disease. We will be looking for some volunteers for next June in Colorado. So if you think you want to be a model for us in Colorado, let us know earlier the better. You can talk to Linda Montgomery on our team, and she can put you on our hot list. That once we have a date and time, we'll get you some information. So that wrapped up. And then this weekend, Stacy and I were in Baltimore doing a in-person meeting with a lot of new friends with the Hopkins group. So thanks to Stacy for all of her coordination with the Hopkins team. She did a great job and even took over the mic duty running around playing Oprah, which is what we used to call it back in the day. So that was great. And for all of those we met there, it was lovely to spend some time with you. And we really hope you got a lot out of the day. So all of that happened over 3 weekends and a lot of travel. And I'm still tired, but I'm getting there. And when I got home, one of our projects that we were working on almost most of the summer, I should say, came in. So this is a new activity book that is part of our All Hearts Collaborative initiative. And as you can maybe take by the cover, it's about knowing your family heart health history and looking at that family tree. So this will be available online shortly for bulk purchases. It's got a bunch of different anatomy pictures and, connect by numbers and all kinds of fun stuff. I love the maze. We made a maze out of a heart. And it teaches families the most important thing of all, and that is to think about family heart health history and does include a family tree. And there's our back of the book. We've also gotten little crayon boxes, and we're stuffing crayon boxes. So if you're in northern New Jersey and want to come out to the office and help stuff crayon packages, we are looking for that help right now. So if you're in the area, let us know. You can come on by and help us out. The goal of this particular project is to not only bring it into the communities where we're bringing All Hearts, but we are also going to the American Academy of Pediatrics at the end of the month, and we want to disseminate this among pediatricians. Hopefully, pediatricians will get the message and start talking more about family heart health history. So Julie and I will be out in Colorado at the end of the month. There is a meet and greet associated with that. So if you would like to come out and see us, we're going to do a small meet and greet in Colorado. I don't remember the day. It's on the calendar, so you can take a look at that. And of course, our annual meeting is coming up on October 19th, 18th and 19th, I should say. 18th is a patient meeting, a CME meeting for sonographers and community-based physicians. And then we have our gala that night and the 5K on Sunday. If you cannot be there for the whole weekend and you can participate in a part of it, please sign up today. If you want to sponsor somebody at the or sponsor a team or do a virtual 5K along with us, if you can't be with us, there's those opportunities online as well. So that's pretty much what I got. Super happy about our little activity booklet, and can't wait to get that into the hands of families all over the country. And on that note, I am going to tap out because I got to go run down to a golf outing and say some words that they're supporting HCMA, as a family member had passed away over 20 years ago now from HCM. So we thank the Dooley family for their continued participation and organizing of their golf outing in memory of their loved ones. So I'm going to be heading down to that in a little bit. And I look forward to seeing you all in an upcoming podcast or webinar. Oh, wait, Melanie has a question. I've obstructed HCM, haven't felt well. Wait, let's see what you say, honey. Since October, not eligible for Camzyos and myectomy wouldn't help. BP goes. So these are the non-obstructed trials that we were just talking about. There are some additional trials coming out for people who are not eligible for the current label of Camzyos because they don't have a gradient over 30. They're not eligible for myectomy because they don't have an outflow tract gradient or even a mid-cavity gradient. These are patients who are non-obstructed. We do know that there is a gap in care for those with obstruction or non-obstructed HCM, and we are desperately looking to bring more therapies into this space. So the trial that we're doing on SGLT1/2s with Lexicon, you would qualify potentially for that trial. Maybe that will help a little bit. And then the Embryo trial, which is Ninorfaxten, I always pronounce that name wrong, I'm sorry. That is going to be opening up in the fall. So if you're interested in those clinical trials, give us a call. We can talk to you about when they're opening up and get you aligned with a coordinator so that you can see if that is something that you want to do or not. We know that clinical trials are critical to getting treatments into the hands of patients, and it takes all of us to participate in trials when we are able to. We need to be well enough, and we need to be engaged enough, and it does take time. It does take, some resources to get there. Let us know if there's any barriers to you participating, and we'll see which barriers we can help you overcome. Okay, and that's all I got to say today. I hope you're all well, taking care of each other, and that you tune into Tales from the Heart the next time we're here. And also remember to check all of our online content. You want to learn more about HCM, it's all out there. We got lots of resources for you. And if you need some help, give us a call at the office at 973-983-7429. Wishing you all the best. Take care. Bye-bye.